All right, for the last two talks of the afternoon, we're going to get started now. So I'd like to introduce Dr. Faustine Ramirez. She's a primary care sports medicine doctor who cares for children and young adults. She earned her medical degree and completed a residency in pediatrics at UCSF. She completed a fellowship in primary care sports medicine at Stanford University. Wrong town for that. And then she also, in medical school, she received several honors, which included graduated from UCSF with distinction, as well as an election to the Alpha Omega Alpha Honor Medical Society. During her residency, she received an award for a commitment to her career in sports medicine from the American Medical Society for Sports Medicine. She was also the inaugural recipient of an award for exceptional academic achievement from the UCSF Pediatric Residency. I'd also like to introduce Gina Biviano. She joined the UCSF PlaySafe athletic training staff in the summer of 2010. She was promoted to manager of athletic trainers and the PlaySafe program in 2021 and oversees all aspects of the services the athletic training team provides in the UCSF Sports Medicine Clinic, as well as all of our member schools. Prior to UCSF, she received her master's in kinesiology from San Jose State University while working at Santa Clara University as a graduate assistant athletic trainer. She also has a bachelor's of science in athletic training from Chapman University. She currently is an active in the California Athletic Trainers Association as a member of the Governmental Affairs Committee working to further promote the athletic training profession in California. And we will get going with that.
Thank you, everyone, for sticking it out to the end of a 2-day course. It's appreciated. I'm really happy that we were asked to present this topic to you all today. It's one near and dear to both Dr. Ramirez and our hearts. As former collegiate athletes and now weekend warriors ourselves, we can probably attest to the gaps in caring for female athletes we're going to talk about today, both personally and also now professionally. So let's dive right in. We have no disclosures. And so our objectives for the next 30 minutes is going to be a bit of a whirlwind, but we want to address the limitations that we feel like exist in treating female athletes. We're going to define the syndrome of REDS for you all, relative energy deficiency in sport, and identify its adverse health outcomes among female athletes specifically. We're going to understand how to screen for and manage adverse REDS outcomes in female athletes in the primary care setting, so hopefully pretty applicable to you all, and discuss future directions for research in our compassionate care of female athletes. Starting with some definitions, we recognize that gender can exist on a spectrum, but for purposes of the next 30 minutes, we're going to talk about sex-based differences and not gender-based differences. So taking the definition from the National Institute of Health, female is sex assigned at birth, recognizing that it's a biological construct based on anatomy, physiology, genetics, and hormones, and those that have XX chromosomes. So for the purposes of how we go forward for the next 30 minutes, we're talking about females in that framework. I always like to have people start to think, especially at the end of the day. So just as a thought experiment here, do you treat male and female athletes at any level, any age, any level of sport differently in your practice?
Yeah.
I think 10 years ago I would have said no, because I want to treat everyone the same. Should we? The next question is, should we treat male and female athletes differently?
Yeah.
I hope by the end of this that we're all saying an enthusiastic yes. As far as limitations when we're talking about treating the female athlete, most of this is from a consensus statement that just came out from the American College of Sports Medicine in the fall. And if you haven't read that, I would encourage you to go read it. It's titled The Biological Basis of Sex Differences in Athletic Performance, a consensus statement from the ACSM. And so the primary goal of this statement is to provide the latest scientific knowledge and mechanisms for sex differences in athletic performance. And so this is a very lengthy paper. However, to summarize, it wasn't until 1993 when the NIH mandated the inclusion of females in human studies. And so for past and present studies of athletic performance, acute exercise and exercise training involved testing of more males, or it was not distinguished whether there were differences between male and females in the population that they were studying. And so that leads us to overwhelming evidence that we know very little about the physiology of female athletes in comparison to males, and we know less about the limits of our athletic abilities and the acute and adaptive response of females to exercise and training. If we look just into sports medicine, I've just taken 2 examples because for sake of time. And also, if I were to ask my high school athletes, female athletes, what worries them the most, number 1 would be ACLs. And number 2, because I'm at a very academically rigorous high school, would be concussions. And so if we look just at ACL and concussions, the ACL injury rate for females has not changed much in 20 years. And females remain 3 to 6 times more likely to experience this injury compared to males. At the same time, research has shown us that neuromuscular training reduces the risk of injury in female athletes by 72%. So if we know both of these things, what's the gap? What's happening between we know there's a higher risk and we know that neuromuscular training, strength training that we've talked about a lot today, can help to narrow this gap and we're not doing it. So I know this is multifactorial and I'm not here to give you all the answers today, but it's something to think about, right? Because we have this opportunity to really affect change and it's not happening. So how can we as the healthcare community promote that? The thing that really keeps me up at night is that we also know when we talk about ACL reconstruction is that females have a 2 to 9-fold increase in relative risk of ACL re-rupture. So that means to me that everyone in the healthcare process plays some role in reducing this. Everything from surgery to our physical therapists, to our athletic trainers, to our primary care doctors doing PPEs. There's some gap that we're not filling here. And I don't think that we know the answers to that. And I'm not going to tell you the answers today, but I do know there's very brilliant people working on these answers. And I think we have to figure out what they are so we can better service our female athletes. And if we shift to concussions, we also know that female athletes are more susceptible to concussions. They have prolonged symptoms after a concussion, and they're more likely to report concussion symptoms. So if we also know this, I find myself doing it. I say the same thing to females as males as far as how long this concussion is going to last. Because the number 1 question is, when can I get back to sport? And so I think we have to have some culture change. We have to have some recognition that maybe we need to be saying our answers to these athletes should be different. So as far as what do we know, what resources do we have, I'm going to point you to our 5th edition of the AAP's pre-participation physical evaluation monograph, PPE going forward here. In chapter 7, there's a whole chapter on female athlete and the differences and what we should be asking and things that we should be looking at. And so I've highlighted just a handful of them here as far as musculoskeletal injury. So some more questions to dive into, and then the key points and how you would refer if these were in your office. Also on neurological conditions, so around surrounding concussions and head injuries, nutritional concerns, weight gain, and then of course menstrual history. So all of this I recognize takes time. And, Dr. Cheng did a lot about history taking. It just takes a long time. And I think for our female athletes, maybe the answer is we just need to take more time and ask more questions. And so as far as what else we know, I'm going to pass it over to Dr. Ramirez to present a case. And so I hope that, at the end of this, that we're really thinking about all the different ways we can approach female athletes as far as treating them better.
Thanks, Gina. So I'd like to start us off with a case. This is a 16-year-old female soccer player who presents to clinic with atraumatic right midfoot pain for several weeks. Her pain is exacerbated during soccer and running, but more recently she started to feel pain with daily activities, including ambulation. And she trains an average of 15 to 20 hours a week. So I'd like you to take a second here and think about what additional history would you like to obtain at this point. And we will pursue this case throughout the rest of the time and get more information as we go along. So just take a few seconds here and think about what questions would be really important to ask this 16-year-old female soccer player. So now I'd like to introduce the concept and go over some definitions of relative energy deficiency in sport, or REDS, as we'll be referring to it moving forward. So these definitions and this diagram, which we'll get to in a second, are from the most recent International Olympic Committee consensus statement on REDS, which I highly recommend if you have not reviewed it. And this was an update to the original statement. So REDS is defined as a syndrome of impaired physiological and or psychological functioning experienced by both female and male athletes that is caused by exposure to problematic, which is either prolonged or severe, low energy availability. And low energy availability is defined as any mismatch between dietary energy intake and energy expenditure in exercise that leaves the body's total energy needs unmet. And it's important to recognize that low energy availability may be intentional, but it may also be unintentional when you have that mismatch between energy expended and energy intake. And problematic low energy availability, again, either prolonged or severe, is really associated with a very wide range of adverse REDS outcomes. And I'm sorry that's a little bit small, but hopefully you can still see the diagram. But you can see that these detrimental outcomes include, but aren't limited to, decreases or impaired metabolism, reproductive function, musculoskeletal health, immunity, glycogen synthesis, cardiovascular health, hematological health, a really wide range of different adverse physical outcomes, as well as adverse mental health outcomes. There's also a similar diagram correlating to impaired performance, which we unfortunately don't have time to go into today, and I'll be focusing more on these adverse health outcomes. But this is important to consider that it affects not only physical health, mental health, but also performance. And the most well-documented adverse health outcomes of REDS are impairments of reproductive function and bone health. And we'll spend a little bit more time going over these in more detail. And although REDS involves both female and male athletes, the majority of the research that's been done so far has been focused on female athletes, and we're just starting to explore further the consequences of REDS in male athletes. So there's a lot more research now on REDS in male athletes, but for the purposes of our talk today, we'll be focusing on female athletes. So let's dive in a little bit to talk more about impaired reproductive function in females. So some potential manifestations of this include primary amenorrhea, oligomenorrhea or other menstrual irregularities, as well as secondary amenorrhea, which we often refer to as functional hypothalamic amenorrhea. And when I'm seeing a patient in clinic and I'm thinking about how do I get some additional history to start screening for this, there are several questions about the menstrual history that I would consider. And I think it's important to remember that these are screening questions that can be asked by all healthcare providers, whether you're in the clinical setting, whether you're in a physical therapy visit, in training room as an athletic trainer, on the sidelines if you're evaluating an athlete. So really all healthcare providers can start to screen for some of these signs and symptoms and have a role in starting that evaluation if there's concern for REDS. So in terms of menstrual history, I think it's important to dive deep and ask questions about age at menarche, last menstrual period, number of cycles per year, duration of periods, duration of time in between cycles, contraceptive use, especially if patients report regular periods, you definitely want to follow up and ask if they're on any form of contraception. If they ever had a period of time where their periods were regular, or were they always irregular? And so these are some of the questions that I asked to try to take a deeper dive into menstrual history. And I really want to emphasize the importance of normalizing the menstrual history. And the way I do this in clinic is I start out by, offering an explanation as to why I'm asking these questions, because they can sometimes feel a little bit intrusive, and explain that they really correlate to overall health. And when I think about my athletes, I want to think about them comprehensively and how these different aspects of their health may relate to the given musculoskeletal injury that I'm seeing them for in clinic. And then I follow up by just saying I ask these questions of all of my female athletes. I also recognize my positionality as a female provider, and that it may be more comfortable for a female patient to share this information with me. But I really want to emphasize the importance of normalizing these questions for all healthcare providers. And then in terms of next steps in management for a primary care provider in the primary care setting, if there's any concern for these symptoms, I would start with labs to exclude other causes of either primary or secondary amenorrhea. If that's something that you're not comfortable with, you can always refer to endocrinology to start that process. Or if there are any abnormal labs that come back on that initial screening process, a referral to endocrinology to work up other causes of primary amenorrhea or secondary amenorrhea. And then once other causes have been excluded and there's a persistent concern for functional hypothalamic amenorrhea, a referral to a primary care sports medicine specialist can continue that REDS evaluation if you have concerns. So let's continue our case and get a little bit more information. So on further questioning, our patient reports menarche occurred at age 12. And a reminder, she was 16. More recently, menstrual cycles have been sporadic. Over the past year, she has only had 3 or 4 periods. Prior to this, periods were regular, occurring once a month on average. Her last menstrual period was 4 months ago, and she is not taking any form of contraception. So moving on to another really important issue as part of the Rett syndrome is mental health issues. And it's important to recognize that mental health issues are actually both risk factors, but also consequences of Rett's. And these are more prevalent in female athletes compared to male athletes. Potential manifestations range anywhere from clinical mood or anxiety disorders, including depression, bipolar, general anxiety disorder, but also include disordered eating behaviors, which we'll touch on a little bit more next, as well as clinical eating disorders. And for those who may not meet the clinical diagnosis of a disorder, they may still have psychological symptoms. So these include depressive symptoms, increased stress, anxiety symptoms, mood changes, sleep disturbances, or body dissatisfaction or body dysmorphia. And in terms of screening questions, in clinic, we often use screening instruments like the PHQ-2 or the PHQ-4, which is on your PPE form, or the GAD-7. But it's also appropriate, depending on what setting you're in, to just take a focused history and check in with athletes about how they're doing and how their mood has been, and if they're experiencing any of these symptoms. How are they sleeping? How are they feeling? How are their stress levels? And I think often in settings like training room or a physical therapy office where there's a really good rapport with a physical therapist or an athletic trainer, they may be more willing to share some of these symptoms about how they've been doing rather than a provider that they're meeting for the first time in clinic. In terms of next steps in management for a primary care provider, if indicated, referral to mental health services, and those can take a wide range depending on the setting. It's important to recognize that these issues may be exacerbated by social media influences, which are very prevalent, as we all know, in our society today, different societal pressures, different performance expectations, whether those are expectations from the athlete themselves or from parents or coaches or the training coaching environment, and specific demands of the sport. Let's focus a little bit more on disordered eating behaviors and eating disorders. These are more prevalent in athletes compared to non-athletes. So disordered eating behaviors are behaviors that exist along a continuum or a spectrum between optimized nutrition on one side and clinical eating disorders on the other side. And so there may be instances where there are concerns about disordered eating, but the patient may not meet DSM criteria for an eating disorder, but certainly still concerning. And so these are risk factors for the development of low energy availability, in this case specifically intentional low energy availability, as well as the development of REDS. So in terms of screening questions that any healthcare provider can ask, again, looking to take a pretty comprehensive history and asking questions in different ways. Sometimes you can get at information in different ways by asking it. So I like to ask about any special diets that the patient or athlete may be following. For example, if they avoid any certain food groups. So are they gluten-free? Or do they follow a low-carb diet? Or are they following a low-dairy diet or vegetarian or vegan? And sometimes patients would be more willing to share that they're following a special diet as opposed to acknowledge that they may be avoiding certain food groups or restricting. But that can raise some red flags if they're following several different special diets. And so I always follow up by asking them again, why are you following the special diet? Another red flag for me is when patients report that they eat very clean. Something worth following up about. I also ask them how many meals per day are they eating? Trying to get out, are they eating breakfast? Are they eating lunch? Are they skipping any meals intentionally or unintentionally? Are they eating pre and post workout? Because if they're exercising regularly, they should really be having both a pre and a post workout meal or snack in addition to their 3 meals per day. Do they have any weight concerns? Do any people around them have any weight concerns? What's the composition of their meal? Is it an entire plate of lettuce, or are they eating carbs, protein, vegetables, well-rounded meals? Do they count calories? Do they restrict their intake? And I don't always ask every single one of these questions, but depending on the circumstances, sometimes I have to dig a little bit deeper and we'll start diving into some of these specifics. In terms of next steps in management for the primary care provider, this depends a little bit on the circumstances. So I always think it's appropriate to refer to a dietitian, and if you have access to a sports dietitian, that's even better. If you're concerned about REDS, referral to a primary care sports medicine specialist for a REDS evaluation. And if there's concern for a clinical eating disorder, then I think it's also appropriate to refer to psychiatry and an eating disorder specialist. Depending on whether that's a pediatrician who specializes in eating disorders or adolescent medicine, depending on what you have, what resources you have access to. So let's continue our case. Our patient also reports recent difficulty sleeping over the past few weeks. She has been more anxious and stressed out as she's concerned about her ability to participate in her upcoming soccer tournaments due to her foot pain. On dietary history, she reports a sensitivity to gluten and dairy, so she avoids gluten-containing foods and dairy most of the time. Otherwise, she reports eating a well-rounded and healthy diet, and she sometimes misses dinner because soccer practice occurs at the same time as her family's dinner. She denies any intentional restricting of her intake or intentionally skipping meals. Finally, let's focus in on bone health, which is another one of the more well-documented adverse outcomes of REDS. So some potential manifestations of impaired bone health in REDS include impaired bone mineral density, as well as the lack of expected bone mass accrual in adolescence during the time of peak bone mass establishment. And I think this is something that's really unique to our pediatric female athletes, is that the majority of peak bone mass is established by age 18. So if there's any concern about low energy availability contributing to impaired bone health during this time, it's important to remind athletes that the majority of their peak bone mass is actually accrued now, and this is going to have long-lasting implications for the rest of their lifetime. Thinking about their risk of developing osteoporosis and fragility fractures later in life, and these behaviors that they have now and the impact of this low energy availability really will follow them for a lifetime. And so I think it's especially important to address this because of that importance of the peak bone mass accrual during adolescence, and it's especially in early adolescence. And then also bone stress injuries, ranging anywhere from bone stress reactions all the way to stress fractures. So screening questions here, I always ask about a history of prior bone stress injuries, and I also take a dietary history that's focused on intake of dairy as well as other foods or supplements that include vitamin D and calcium. In terms of next steps in management for the primary care provider, I always recommend checking a vitamin D level, and remember to check a 25 OH vitamin D level, not a 125 OH level. Vitamin D and calcium supplementation can be started in the primary care setting. The RDA for vitamin D is 600. That's fairly low. You can safely start at 1,000. And for calcium, it's 1,300 milligrams per day for 9 to 18-year-olds. We don't have very well established guidelines for vitamin D levels in athletes, especially female athletes, but it's suggested to be higher than the reference range that your lab will give you, probably closer to the 40s, maybe even in the 50s, but we don't have well-established guidelines for that. Similarly, we don't have well-established guidelines for calcium and vitamin D supplementation in athletes, specifically female athletes, but higher levels have been suggested, especially for those who have REDS, as high or potentially starting at calcium of 1,500 milligrams per day or vitamin D of 1,500 to 2,000 IUs per day. But again, that has been proposed but not well defined. And these are things that I always discuss with my female athletes if I'm concerned about REDS, and I often will use vitamin D levels to guide supplementation, but I think starting with the RDA in the primary care setting is really appropriate, and then we can further that workup in the primary care sports medicine setting. And then referral to a primary care sports medicine specialist for bone health optimization, or if you have any concern for a bone stress injury. So case continued. On physical exam, our patient has full pain-free ankle range of motion and strength, focal tenderness to palpation over the navicular, a non-antalgic gait, and foot pain with single leg hop. So in conclusion for our case, I'm going to go over how I would approach this case in a primary care sports medicine setting. So you have an idea of the type of comprehensive evaluation that the patient may get if you place that referral, and kind of how we think about these different elements. So her midfoot pain to me is very concerning for navicular bone stress injury. So I'm going to order an X-ray, an MRI to evaluate for bone stress injury. And I recommend activity restrictions. In this case, complete cessation of impact activities given my concern while I'm waiting for the MRI results. If appropriate, depending on the bone stress injury, you would want to immobilize. In this case, I would immobilize with a cam boot. And because of the nature of the navicular being a high stress bone stress injury, I would make her non-weight bearing while awaiting the MRI results. And I would also start vitamin D and calcium supplementation, all the while also ordering a vitamin D level. Her secondary amenorrhea is concerning for functional hypothalamic amenorrhea. And so I would order labs as part of this initial evaluation. And her disordered eating behaviors are also concerning to me. So I would offer some nutritional counseling in the visit, refer her to a sports dietitian, as well as to sports psychology. And overall, her presentation is concerning for Redd's syndrome. And although we've only touched on several manifestations of Redd's, including bone health, reproductive health, and mental health, I would also want to evaluate for other consequences of Redd's. And so these are some of the labs that I would order for that evaluation. And this is just what my panel looks like, and there's certainly variability from provider to provider, but this is what I would start with. I would get a CBC with diff, I would get a ferritin, potentially iron studies, an estradiol level, vitamin D level, a total T3, as well as a TSH with reflex T4. And this would be to evaluate for other manifestations of Redd's beyond the ones we discussed today, and to help with our workup and management of this patient. So I'm gonna pass it back over to Gina.
Thank you, Dr. Ramirez. So just with our we did good on time. With our last 3 minutes, just to end kind of with some more thought. Again, no answers, but thought is, when we were talking about this case, how do we prevent these things from happening in the first place? Right? And how do we prevent them from happening disproportionately to female athletes? How can we as a healthcare community raise awareness, but at the same time comprehensively address these unique aspects in our very, very busy practices and busy lives to really help support our female athletes? And the goal really is, how can we encourage more female participation for the lifespan in athletics and physical activity? Because we all know the health benefits that we have by doing that. And I think, the long and short is that more research is needed in so many different areas for us to really be able to provide high level care to female athletes. And so as far as future directions, and again, this was taken from the ACSM paper, is just some things that they threw out. And this is highly summarized. It was 2 pages, single space, so you're welcome. That's only on one side. But things that they brought up is like a mandate to include sex as a biological variable across all studies of athletic performance and exercise science. Just an idea. Declare the sex of participants in the title and the abstract, so people know exactly what this is about. And then studies, again, they had so many ideas for future directions, but really looking into the long and short-term consequences of lower participation of females in sports that we know existing, the role of social determinants of health, of puberty and mini puberty, and performance effects of the menstrual cycle and hormone therapy, use of contraceptives. All of this could be further studied to help us provide better care. And lastly, we just want to end with a call to action to really try to increase female participation in sport. We know that by age 14, girls are dropping out at sport twice the rate of boys. And the Aspen Institute has looked at this in detail, and 41% of girls, and these are from individual interviews as to why they're discontinuing sport. And of the age group 11 to 16, 41% report that low body confidence is the main factor, and fear of judgment from others. So there's lots of great organizations that are doing a lot of work in this space. You may have seen a Dove commercial in the Super Bowl pointing out these stats. Nike has joined and they're doing a coaching campaign to try to increase by 26,000 female coaches, because we know representation matters. So I think all of these things are encouraging. As a basketball player, a lot of buzz around March Madness, and specifically the women's tournament, I think is also very helpful. So I hope that we can ride these coattails and really try to provide really high level care to our female athletes going forward. So with that, we have all of our references for you in the syllabus, and we're going to stick around to do questions after the next talk. Thank you.